So, good evening, doctors and all the participants. So, I Shumon on behalf of Shield Healthcare, welcoming you all today's with Dr. Swati Sri Ramesh Madam on non-hormonal treatment in menopause. Just before moving into the session, let me introduce Madam. And it's my honor to introduce Madam. Madam did her MSOG from Madurai Medical College, a diploma in ERT, the University Medical Center, Holstein, Germany, and post PG experience 9 years. So at present, Madam is attached as a consultant obstetrician and gynecologist at Harshita Hospital Private Limited, Madurai. So in this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for your active participation, and please post your queries related to the topic in the dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time in our platform Shield Connect, and over to you, ma'am, for further postings. Thank you very much.
Good afternoon, sir. Good afternoon, everyone. Today, we are going to have a look on non-hormonal treatment in menopause. As we all know, estrogen is the important female hormone, and that hormone rules a woman's body from head to toe and from her menarche to menopause. When estrogen level starts declining, the woman may experience multiple physical as well as psychological symptoms. We all know that the treatment for that symptom is hormone replacement therapy. But hormone replacement therapy has got its own limitations and side effects. So, what to do for those patients who come to us with the symptoms of menopause where we cannot use HRT? So, there comes our non-hormonal treatment. So, with this introduction, we move on to the topic. So, the menopause is permanent cessation of menstruation, which is confirmed after 12 months of amenorrhea. Usually, the woman attains menopause by the age of 51. It can be a natural menopause or due to some treatment like chemotherapy or surgical menopause. The types may be either natural, surgical menopause, or premature menopause. So, on an average in India, the woman attains menopause by 41 to 49 years of age. A very few women may attain menopause before that, around 3% in the age group of 30 to 34 years and 8% in the age group of 35 to 39 years. So, hypothalamo-pituitary axis. Gonadotropin releasing hormone is released from the hypothalamus, which acts on the gonadotroph cells of the pituitary, and FSH and LH are released from the pituitary that acts on the granulosa cells and Thico cells respectively. So, from the granulosa cells, estrogen is released. This estrogen has a negative feedback mechanism over the pituitary, and it reduces the levels of FSH and GnRH by acting on the hypothalamus. So the estrogen acts on the uterus, helps to prepare the uterus for embryo implantation and fetus development. It acts on the breast and it helps in ductal proliferation and healthy development of breast tissues. It helps to maintain a lubricated vagina and integrity of the urethral and genital epithelium. It helps to maintain psychological well-being. It regulates the cholesterol metabolism, is cardioprotective. It regulates normal temperature and respiration, regulates the fat metabolism, helps to maintain bone mineral density, and helps to maintain collagen synthesis and skin integrity. So the causes of menopause can be either due to natural follicular depletion due to aging or surgical removal of the uterus and ovaries. So the stages in a woman's life can be divided into 4 stages. One is the premenopause, where the first menstrual cycle or menarche begins to first signs of menopause. Perimenopause is a few years preceding the menopause, where the estrogen level starts declining and fluctuating. The patient may experience menopausal symptoms in the climactic or perimenopause stage itself. Menopause is cessation of menstruation, and post-menopause is after menopause until the end of the life. That is after 52 years. So it is again the same. Perimenopause or climactic, where the woman starts experiencing the unpleasant symptoms due to reduction in the estrogen level. So what happens to the estrogen affinity to the receptors after menopause? There will be upregulation of estrogen affinity in the reproductive organs and downregulation of estrogen in the non-reproductive organs, which is responsible for the menopausal symptoms. The patient may come to us with menstrual symptoms or with vasomotor or with vulvovaginal symptoms. Of these, the most common includes menstrual and vasomotor symptoms. The other symptoms include dizziness, fatigue, poor memory, mood swings, irritability, vasomotor hot flushes, and due to dryness of urogenital epithelium, the patient is prone to develop recurrent urethral infection, urinary infection, vaginitis, urinary incontinence, etc. Estrogen is very important for the calcium absorption. When estrogen level falls, there is reduction in the bone mineral density, and that leads to osteopenia and osteoporosis. Weight gain and changes in the fat distribution increases LDL and triglycerides. Thereby, the woman is prone to develop myocardial ischemia and infection, dryness, itching, wrinkling due to decrease in the collagen synthesis. So, how to diagnose menopause? One is with the symptoms. The other is with biochemical increase in the FSH levels more than 40 international units per month and decrease in the serum estradiol level, which is the most important estrogen, less than 20 picograms per ml. So, how to approach to a woman who has come to us with menopausal symptoms? As we already discussed, the patient might have come to us with menstrual bleeding. She may have either lighter bleeding or heavier bleeding due to anovulation in the climactic or perimenopause stage. She may come to us with vasomotor symptoms, recurrent transit episodes of flushing, accompanied by a sensation of warmth to intense heat on the upper body and face, which is seen in more than 70% of the women in climactic and menopause phase. It reduces in intensity and frequency as age progresses. Within 5 years after menopause, it will start decreasing in frequency as well as intensity. The patient may have vaginal symptoms like dryness, irritation or itching, dyspareunia, and this is seen in less common individuals, 10 to 40% of the postmenopausal women. Unlike vasomotor symptoms, vaginal symptoms are typically progressive and unlikely to resolve on its own. So the treatment includes local vaginal estrogen or non-hormonal lubricants and moisturizers. So this picture illustrates the vaginal atrophy. Decreased estrogen causes decrease in the vaginal lubrication and elasticity and also decrease in the sexual desire and libido. And we should not forget about the sexually transmitted infection screening because the patients have vaginal atrophy, which increases the risk of contracting an STI. They may have sleep disturbances that might be due to menopausal symptoms or general aging delays. Women should be counseled that memory and concentration problems are probably not related to menopause, but rather to normal aging and or mood stress under the lifestyle circumstances. Feelings of upset, loss of control, irritability, fatigue, blue moods, or dysphoria with life can be caused by fluctuating hormone levels. Women with a history of premenopausal syndrome, significant stress, sexual dysfunction, physical inactivity, or heart flushes are more vulnerable to develop depressive symptoms during menopause. Urinary symptoms, over 50% of women after the age of 50 years experience urinary incontinence. It may be due to stress urinary incontinence or urge incontinence. Mild incontinence in early perimenopause tends to decline in the first 5 years after menopause. Weight loss is very effective. Kegels exercise can cure more than 50% of the patients with stress incontinence. So the management for all these symptoms is traditionally we were using hormone replacement therapy, either conjugated estrogen alone or estrogen along with progesterone in women with uterus. So there are contraindications for hormone replacement therapy. These are absolute contraindications. Those with undiagnosed genital bleeding, those with active liver and gallbladder disease, those who are having estrogen dependent neoplasm, those who are prone to develop fibroids. In such patients, we can use non-hormonal treatment. So the limitations include HRT can only be used for a short term because it has a potential risk of breast and endometrial cancer because of the increased affinity for endometrial receptors in the breast and endometrium after menopause. So what are the alternatives to hormone therapy? Complementary and alternative medicine includes soy isoflavones, that is phytoestrogens, traditional Chinese medicine, and some herbs which include black cohosh, cranberry, St. John's wort, valerian, and vitis. And we can advise lifestyle changes like relaxation techniques, yoga and meditation, eating a healthy, protein-rich diet, get regular exercise, 30 minutes of walking a day, avoid hot flush triggers like caffeine, alcohol, and spicy food, ask them to dress in layers, sleep in a cool room, consume cool drinks, and reduce sexual discomfort with moisturizers and lubricants. So the dietary modification is high quality protein diet is advised. So non-hormonal drugs include antidepressants like selective serotonin reuptake inhibitors and serotonin noradrenaline reuptake inhibitors like fluoxetine, paroxetine, venlafaxine, and desvenlafaxine. Those who have psychological symptoms predominantly. Those who are having insomnia and sleep disturbances, we can advise esophageal. Gabapentin and pregabalin for neuropathic pain, and clonidine for hot flushes in those women with hypertension. So this is about the dosage of adjuvant therapy. Clonidine is advised 0.2 to 0.4 milligram daily orally. Fluoxetine 10 to 20 milligram per day. Isoclonins up to 3 months we can give. And it is essential to advise women to have calcium and vitamin D supplementation. Regarding the calcium supplementation, we should start with 500 milligram of calcium daily for about a week, gradually adding more to reduce its side effects. Absorption of calcium is decreased when taken with foods rich in fiber and fat, iron, zinc, spinach, alcohol, and antacids. Thyroid medications, corticosteroids, tetracyclines, anticonvulsants, and calcium should be taken separately. Contraindicated in patients with hypercalcemia, renal insufficiency, and in nephrolithiasis. If calcium is taken more than 2,500 milligrams, it may affect kidneys and can reduce the absorption of other minerals like iron, zinc, and magnesium. And it is essential to supplement vitamin D along with calcium to increase its absorption. So during perimenopause and menopausal period, there will be decrease in the bone mineral density. Normal T-score is greater than or equal to -1. We call it as osteopenia if the T-score is between -1 and -2.5. And we say it is osteoporosis if it is less than or equal to -2.5. So if a postmenopausal woman comes to us within 5 years of postmenopause, if she has risk factors for osteoporosis, then we need to screen her bone mineral density. If she has come to us after 5 years after attaining menopause, we should do bone mineral density irrespective of her risk factor. If it is normal, follow up after 2 years and reinforce lifestyle changes. If it is osteopenia without any risk factors, then we can follow her up. If she has risk factors without any symptoms, we can start her on tibolonol by the bisphosphonates. If the patient has bone mineral density, which shows osteoporosis, then we need to start her either on hormone replacement therapy or non-hormonal bisphosphonates and relaxation. The patient has severe osteoporosis, then we can prescribe teriparatide, which is recombinant parathormone or calcium. Menopause as such is not associated with increased cancer risk. Cancer rates increase with age, and it is our duty to screen the women for the colon cancers. So for breast cancer, we need to do every 2 years mammogram after the age of 50 years. For colorectal cancer, colonoscopy every 10 years or fecal occult blood test, or bare minimum every 5 years beginning at the age of 50. Any postmenopausal bleeding must be evaluated properly. If the endometrial thickness is more than 4 millimeter, it is essential to do endometrial biopsy to rule out endometrial hyperplasia and carcinoma. And for ovarian cancer, there is no satisfactory screening test. Regarding the cervical cancer, it is necessary to do pap test every 3 years after a normal report, 3 years in a row for women aged 50 years. Screening is not necessary after the age of 65 with no previous abnormal reports. So, is there any one holistic solution which is effective, fast, safe, and non-hormonal? That is alternative medicine, which has some herbs like cinnamic acid, S-methyl ester, and dequercetin, angelate. So the supplement is named as estrogen 100. It upregulates the estrogen affinity to the estrogen receptor in the non-reproductive target organs. Thereby, it reduces hot flushes and night sweats. It improves mood swings and insomnia. It improves bone mineral density. Thereby, and also reducing the risk of cancer because it downregulates estrogen affinity to the receptors in the reproductive organs. So there are studies which help in cinnamic acid, a natural remedy used for hundreds of years in both Korea and China, has shown significant improvements, and this has been found by Lisa Olivier in 2015. And Vigas powder normalizes ovarian hormone levels and has anti-osteoporosis properties. The effect of herbal extract estrogen 100 on postmenopausal and perimenopausal women has been studied. It is a randomized double-blind placebo-controlled study by Albert Chan, and they have found that with 12-week treatment of estrogen 100, showed statistically significant improvement in the various menopausal symptoms such as hot flash, night sweats, paresthesia, nervousness, etc. And no adverse effects were reported. So this is a double-blind placebo-controlled randomized controlled study. Another study. So to conclude, women live one-third of their lives in the postmenopausal period. In that period, they may be affected with symptoms like vasomotor symptoms, vaginal dryness, and osteoporosis due to hyperestrogenism. In most of the women, hot flushes resolve on its own. As HRT has its own drawbacks and side effects, we can go in for non-hormonal management in those patients where HRT cannot be used. Complementary and alternative medicine is an efficacious treatment strategy. Eating the right diet along with supplements, having adequate sleep, exercising regularly can lead to a blissful postmenopausal.
Thank you very much, madam. Just give me 1 minute time, ma'am, to check the questions, if any, in our dashboard. Ma'am, your voice is not coming. Yes.
Sir?
Yeah, it is okay. It is okay, ma'am. Thank you. So, ma'am, first question is, in case of surgical menopause, what will be the first line of treatment as per your practical experience?
According to the age group.
40.
If she's around 40, we can go in for hormone replacement therapy. If she's prone to develop endometrial or breast cancer, say she has any family history of such cancers, then we can go in for non-hormonal.
Ma'am, hormonal therapy is the first line of treatment. Is it so?
No, it is not the first line of treatment.
And ma'am, how long this HRT can be given for that particular kind of patient to means reduce the symptoms, certain symptoms means related to the surgical menopause?
Most of the symptoms reduce within 5 years after attaining menopause. So 5 years of HRT will do.
Thank you very much, ma'am. And one question is, ma'am, what is your thought on the role of this calcium? Is it necessary all the time you have to give the calcium supplement, or it is based on the case to case?
It is based on the case, it is based on the bone mineral density and the risk factors for developing osteoporosis.
Thank you. Thank you very much, ma'am. One question, ma'am, that is, what is your thought on this isoflavone group of drugs?
It is phytoestrogen. It can be used for around 3 months and it has got good results.
Thank you, madam.
Its results are so promising and it is equivalent to hormone replacement therapy.
Thank you, madam. So, ma'am, thank you very much. I could not find any other question right now. So, if you allow us, then we can complete this session.
Ma'am, thank you so much.
Thank you very much, madam, for your valuable
webinar activities with us, ma'am. So we will be doing continuously activities with you, ma'am, based on your interest, ma'am. Thank you so much.
Thank you very much, madam, once again for your valuable time on our platform Shield Connect, and in future also we will look forward for some valuable sessions with you. So thank you.